Testing one, two, testing, testing. Okay, now it works. Can anybody hear me? Hello, testing one, two.
Yes, we can hear you.
Oh, good. Thank you. Who's this? Matambi Rose?
Yes,
Welcome.
thank you.
Where are you from?
I'm from Uganda. I'm a medical student in fifth year at Makerere University.
Oh, wow. Welcome.
Thank you.
Yeah, we have a medical student group in South America that's really doing well, but unfortunately, it's in Spanish.
I would like to join, then I'll learn Spanish little by little.
Well, you're welcome. My website, Neurosurgical TV, all the events are listed there, and they all have links to come in if you want to come in. Okay, and you're certainly
Thank you.
welcome. You're certainly welcome just to sit and watch. You don't have to really talk.
Okay, thanks a lot.
Okay, we'll see you in a while.
All right.
Mm. Carlos, can you hear me? Carlos Dabdowd? I'm just curious because I don't seem to be able to get you in the panel, but you should be able to hear me. Can you hear me, Carlos? Or Premamesh Adav? Can you hear me? Oh, great. Komi Sharma came in. How are you doing, Komi? Hey, Omar. Omar, did you get in? Omar, you get in? Okay. Perhaps he stepped away.
Hello, Dr. John. How are you?
Good. Yeah, welcome, Abraham.
Thank you very much, John Bennett.
Okay, who's speaking? Is that Abraham? Is that Omar?
Hello, Mr. John Bennett. My name is Awas Ismailov. I am from Uzbekistan. I am one of the young neurosurgery of Uzbekistan.
Oh, good.
So,
Well, welcome.
welcome. I work in the Republic Cancer Center of Uzbekistan, and I performed more spinal surgery. And I was interested more the spinal surgery, craniocervical surgery, and all of the neurosurgery operations.
Well, we
Thank
have,
you
yeah, we have webcasts. We have webcasts in spine. We have a good number of them. We just had one in Spanish from Argentina on minimally invasive spine. And we also have a couple coming up, one from India on minimally invasive spine, a couple of spine conferences coming up. Just watch Neurosurgical TV, the website. You can see what webcasts we're going to televise.
Yes, yes. I always watching the TV neurosurgery.
Yeah.
It's your TV.
Yeah, that's home. That's home.
It's a good one of the best of the TV in neurosurgery
Thank
for
you.
medicine.
Thank you.
Thank you for you for everything for you perform for your attention. Thank you very, very much.
Well, I do it for people like you that appreciate it.
Thank you
And
very much.
that is fun. When people appreciate it, as a doctor, when a patient appreciates your work, it means a lot.
Yes, we take many knowledge in this TV, and we have very interesting videos. Sometimes, so I sometimes see watch these TVs before operations, and it's very interesting. And it's very we have take very many knowledge in this TV. Thank you for you this TV, and thank you for everything for you.
Okay, thank you. Thank you.
Mhm.
Okay, well, we should be starting in a few minutes. A vase? Okay. Okay. Hey, Dr. Sabay, how are you doing? Let me get my, can you hear me okay?
Yeah, of course, yes.
Okay. Yeah, I haven't, good to see you. I haven't seen you for a while.
See you all. كيفك عمر؟
السلام عليكم.
عليكم السلام ورحمة الله.
Okay, let me change my background there. So, yeah, Elena's coming, Dr. Sabaya.
Sorry?
Elena, the
Yes.
from London, she's
Yes,
coming.
from London. Yeah, that's
Yeah,
good. That's good.
she hasn't met your daughter yet, but I think she plans
Yeah.
to.
Hope so.
Yeah, I hope so. Well, you know, that's how things work. You get connections.
Absolutely, absolutely.
Yeah,
Lance.
that's the way the neurosurgery and every specialty works.
Absolutely.
So you've been pretty busy?
Absolutely. Yeah, it's summertime and we have lots of patients coming from the Arab world to Jordan.
Really? That's
Yeah.
a center. That's a neurosurgery center, huh?
Jordan is a medical hub in the Middle East.
Really?
Absolutely, and there is a big income for the Jordan sort of industry, medical industry, something like $1.5 billion every year from
Wow, that's
medical
great.
tourism. Yeah.
That's great. So medical tourism, not just
It is medical,
neurosurgery.
yeah, medical tourism, and we would like to combine medical tourism with actual tourism. Like, if you come, you can also visit Petra, you can visit the Jarash, you can visit the Dead Sea.
That's great.
So, in addition, you know, the Dead Sea is a place for a lot of the treatment of lots of medical diseases like
Really?
psoriasis. And so on.
Rehab for moving problems. I didn't realize that.
Yeah.
I know that Jordan has the only anatomy laboratories, cadaver
Yes.
labs.
This is I established a few years back. Yes.
Oh, really? You established
yes.
that lab?
Yes.
Yeah, if you ever want to televise from the lab, let us know. We'd love to do
Surely.
it.
Just, you know, because of the COVID and things like that, we
Yeah,
stopped
of
doing
course,
any.
of course. Yeah, of course.
Surely.
Everyone has stopped
Yeah.
doing stuff like that. How is the COVID there? Is it going up, down, stable?
Well, stable kind of thing.
Okay. Yeah, some parts of the world is going up again.
Yeah, it's frightening, really.
Yeah, like places like Finland, it went from 10 cases a day to 600.
Absolutely.
Which is not a big number, but Finland, I mean,
Absolutely.
that's a 600% increase.
Yeah, true.
So we're not through this yet.
No, not yet.
Matter of fact, there was one conference that Victor invited me to in November. They opened it up. They thought, great, we're going to have it. But now Mexico is increasing. But it's,
Yeah.
you know, it's in Mexico, it's increasing in the young demographic. Apparently the Delta in Mexico is affecting a younger demographic.
Generation.
So it's not as bad as the original COVID.
Yeah.
Is it the same in Jordan? Is there any Delta variants there?
No.
No.
It's just being there in the old people rather than the young people.
Yeah. Yeah. Certain parts of like Thailand, I guess it's increasing, and things are getting stricter as far as going in public, etc. And China is one of the best countries in the world
Yeah.
with the strict regulations. You know, the case is less than 100 a day in a country full of billions of people.
Yes. Yeah. They worry that after the Olympic Games in Tokyo, lots of athletes will go back to their countries, and then there may be a surge of cases.
Well, that's what happened in Finland. They had a group from Finland that went to Russia, and they weren't strict with the quarantine when they came back, and that's what's causing the increase.
Absolutely.
Yeah, so that's a good thing to be aware of.
Yeah.
The Olympics. I haven't really watched the Olympics. I guess they're still going on, but less people, right?
Absolutely. We got our first medal in Taekwondo.
Oh, okay. Who?
Yeah.
Jordan got a medal?
Yeah.
Oh, wow. Taekwondo.
Yeah.
Great.
And we got the gold medal 4 years ago in Taekwondo.
Wow.
So Jordan now is leading the Arab countries in the number of medals.
Oh, good.
So you see, we are good in medicine and in Taekwondo.
Yeah, it's yeah, I haven't got a chance to watch the Olympics. I'd like to.
It's beautiful.
Yeah. The crowd, the people are still coming, right? They just have a small audience there watching.
No audience. It's without.
None,
audience.
really, just
None.
athletes.
Yeah.
Wow. Okay.
It's a great loss of income for the Japanese because, you know, the audience would pay to attend, but now they have lost that. But I think they increase the income from the televising companies. Yes.
Yeah, good. Let me check with Eleanor here.
Sure, take your turn.
Yep. Yeah, I see you did some webcasts in Japan.
Yes.
Good. And you've been doing in other parts of the world too?
Saturday, we'll be doing one with the Kiki Chorel about
Okay.
the complications. It's going to be on Saturday.
Oh, from India, right?
Yes.
Yeah. And that's a routine, right? Once a month or something?
Absolutely. Yes.
Oh, there she is, Elena.
Sorry about that.
Can you hear me okay?
Issues.
You can hear me okay, right?
I can, yeah. Can you hear me okay?
Yeah. Okay,
Incredible.
Dr. Sabay is here. You look great. Okay.
Hey. Hi, how are you?
I'm fine, thank you.
Okay, I guess, I don't know if you remember.
I'm just going to
Elma,
add my background.
Dr. Sabea, you like to have the questions after your presentation, correct?
Yes, yes.
Okay. So yeah, you can, you know that, Elena. Just introduce Dr. Sabea. I'll introduce you and then you introduce Dr.
Yeah, I mean,
Sabea.
there were some incredible questions.
Oh, hold on, we have some interference here. Hold on.
Mm.
Okay. Yeah, we got 3 minutes. So Elena, how you been?
Good, yeah.
We're getting some weird sounds from your background. Can you turn your sound on a second? Yeah, can unmute there, Elena? You're muted. You're muted.
Is it working now?
Yeah, is there a lot of noise in your background?
Yeah. So we're having like some floods in London, so I'm in a cafe at the moment.
Oh, okay. So I guess you have to make your words short.
I do. I'm very
Okay,
sorry.
all right, no problem. We'll work around it. We'll work around it.
I mean, sorry, is it really loud?
No, it's good. It's good now. Yeah, you don't have, well, you don't need a headphone. Your sound is fine. But yeah, we have a webcast from Latin America. We had 400 panelists.
Oh,
400. Can you mention that, Dr. Sabea?
yeah, I can.
Oh my
That's
God.
incredible.
Okay.
We just hit a good area. Medical students in Latin America.
Yeah,
Is that the NeuroGods one?
Yes, Elena. Yeah, I don't think you speak Spanish, but you ought to check it out. Tonight we have one too. No, it's kind of late for you. It's yeah, it's like 2 a.m. But watch the recorded webcast. It's on Neurosurgical TV. It's very interactive. They have some great kids running it from Peru. That's what it takes, Dr. Sabea. If I get some help,
absolutely.
if I get
Yeah.
some help like from students, that it really makes it easy. They
Yeah.
have it all set up. They have different moderators. I mean, they're really doing a great job.
I think
So-
part of our audience should be medical students because, as I told you, John, that across the world, the neuroanatomy, the neuro knowledge is the Achilles heel of every medical student. So whatever they hear, whatever they participate in, that would be a great benefit for any medical student anywhere in the world.
Yes, we have a medical student from Uganda that I just met before the broadcast.
Yeah.
Are you there, medical student? I'm sorry, I forgot your name. Let me see. Introduce her.
Hello. Yes, I'm there. My
Oh, there
name
she
is
is.
Rose Nantan.
Yeah, this is Dr. Ibrahim Sabea. Rose.
Hello, Rose.
Yes, please.
Yeah, I guess you can't put your camera on, right? No, you don't have to. You don't have to. But this is one of the benefits of meeting people like Dr. Sabea, so they can see your face. Because someday you may go to Jordan to train. Who knows?
Sure.
Okay, we're ready to go. Are you ready, Elena? Elena, you ready?
Yes, I'm ready.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3,
Yes.
2. Good afternoon. Good afternoon. This is Dr. John Bennett broadcasting from Miami Beach. We have another in the Jordan Neurosurgery Grand Rounds, restarting it. And we have a host, Elena from Brainbook. Welcome, Elena. It's all yours.
Hi, everyone. My name is Elena. I work for the Brainbook charity and for Neurosurgical TV. Welcome to another one of our Grand Round Neurosurgery for Dr. Sabay in Jordan. And I hope you
I'm sorry, Elena, we can't hear you very well. Try again. Do again, please. Okay. Well, okay, we're gonna have to edit
We'll
this out.
start. Yeah.
Okay, Doctor, I'd like to
Okay.
introduce, yeah,
I'm
that's
back.
okay, Elena, I'll do it, okay? Thank you, Dr.
No, it's
Surveyor.
okay. I got it. I got
Okay,
it.
okay, go ahead, try again. Okay, well, Dr. Surveyor, why don't you just go ahead? Thank
I
you
will.
very
I
much
will.
for coming.
I will.
Go ahead.
Yes, I'll share my screen.
I hope you can hear me now.
You're gonna have to mute you,
Hi,
Elena.
everyone.
Elena, we're gonna have to forget about the introduction. Dr. Surveyor is just gonna start, okay?
Yeah.
Okay, Dr. Surveyor, it's all yours.
Thank you very much, John. Thank you, Elena. And hello, everybody, wherever you are. Again, for those who don't know me, I'm Ibrahim Sabeh from Jordan, and I'm practicing from the Farah Medical Campus here in Amman, Jordan. The topic for today is tuberculosis, and I choose this title, The Forgotten Disease, because it is forgotten. People think that tuberculosis is finished. It is not. So we'll have an overview of this, and then I'm going to present two unusual cases, one cranial and one spinal, with tuberculosis without any pulmonary tuberculosis. They were affecting the brain and the spinal cord without any evidence of any tuberculosis anywhere in the body. The backdrop of this slide is the black iris, which is the symbol of Jordan. As usual, whenever we take a topic, we will discuss it from the clinical, radiological, operative, and pathological point of view and make that correlation. So we'll start with the tuberculosis and overview. And we must emphasize that it is a worldwide health problem. It still is. I'm going to quote this slide from my colleague, Dr. Montasser Belbisi, who is an infectious disease specialist here in Amman, Jordan. He's an American boarded of infectious diseases in Mayo Clinic, USA. He's practicing now in Jordan. This is one of his famous slides. To be TB or not TB, after Shakespeare. And this slide showing this phagocyte eating those roots of tuberculosis. So there is resurgence of tuberculosis with the outbreak of AIDS, acquired immunodeficiency syndrome. There is increasing frequency in other immune compromising patients. So it is not only in the immunodeficient, but it is also in the immune competent. The tip of the iceberg started in '78. This paper by J. Tyson, Surgical Neurology, and this paper by Trella in Medical Clinic, and Martinez in the AIDS Journal, 78, 89, and 95. Tuberculosis abscess in HIV-infected patients, 3 patients from the same country of Spain. That's the tip of the iceberg. Another paper, 93, from States, published in Neurosurgery, the abscess or tuberculosis abscess in HIV-infected patients. That came from France, sorry, not from USA, from France. And this paper in 2005, tuberculosis mortality trends increasing in Taiwan, a resurgence of non-respiratory tuberculosis. From Iran, 2014, central nervous system infection, review of tuberculosis, review of re-emerging disease. People are trying to tell us, be careful, don't write the tuberculosis down. It is still there and it is researching. And this cover of the Time magazine, 2012. And the title, Why Drug-Resistant Tuberculosis Threatens Us All. And again, I'm taking the slide from my friend, Dr. Belbisi. 2013, WHO report, 9 million population in the world developed tuberculosis. Out of these, 2 million died of the disease. This is dangerous. Look at the WHO report in 2016. It is increasing, and you can see the color. The colors here, you are talking about large numbers, these countries like this. So whenever the color is it's darker, then there is infection. And this also WHO report 2017. Again, the colors show that. So you're talking about 6% affected in these countries like this or that. So 117 countries are affected with estimated 500,000 people. Again, dangerous notion. So it is increasing both in developing, underdeveloped countries, and in the developed countries. So don't think that developed countries are safer from it. Look at the numbers. Developing, underdeveloped countries, 110 to 165 cases per 100,000 population per annum. And in the developed countries, it's still there, 9 cases per 100,000 population per annum. Why should we have resurgence of tuberculosis in developed countries? It has resurged, it has increased in the developed countries in the last 10 years, and the causes are obvious. Immigrants, and you have seen lots of problems with immigration in the last 10 years, camps, poor sanitation, poverty. In the developed world, we are using immunosuppression for major types of transplantations, for example. Lots of alcoholism, again, lots of homeless people. Aggressive chemotherapy, which takes down the immunity. Increasing age, like in Japan, and the development of drug-resistant strains. All these causes has increased the number of tuberculosis infected people in the developed countries. So there is a global increase of tuberculosis, both in the immunocompetent and in immunocompromised patients. And the problem that 70% of these patients are above the age of 20. Again, this slide is courtesy of my friend, Dr. Belbisi, infectious disease consultant here in Amman. And you can see the curves. Here, this white, which is better diagnosis. With better diagnosis, you can save lives. With better treatment, you can save lives. If you use better diagnosis and treatment, like in this curve, you will save lives. So lots of lives can be saved by the year 2025 if you actually we are aware that tuberculosis is there, and we make our effort to better diagnose it and better treat it. Tuberculosis basically caused by mycobacterial tuberculosis, human-to-human transmission. It is hematogenous spread. And we have another type, it's Mycobacterium bovis, which is infection from animal that passes to the human, which is very rare. So basically, you are talking about Mycobacterium tuberculosis. There are other strains of Mycobacterium. Let's look what happens when somebody gets infected. If somebody gets infected, primary infection will go to the lung, the caseation in the lung, the primary disease would increase. So we're speaking about progressive primary tuberculosis. And this may progress to massive hematogenous dissemination, and this will proceed to medullary TB. So this is one way of progression of the disease. Other way that you got infected here, caseation, but then it is healed, scar, so you will have healed lesions. Again, here, if you look at this caseation, it will not just stay like it is. It will be latent lesions. The organisms are dormant. Then somewhere there is reactivation by so many factors, and then you'll get secondary tuberculosis, progressing to progressive secondary tuberculosis, massive hematogenous dissemination, and medullary TB. So this is how you progress into a primary tuberculosis or a secondary tuberculosis. So the main entry point for tuberculosis are the lungs. Pulmonary tuberculosis, whether in chest X-ray or in CT scan, you can diagnose it with pleural effusion in this case here. And then it can go from there to other organs. I'm just mentioning a few. Let me just make it easier. Any body organ in the body can get infected. There is not a single organ which can be safe. But mainly from the lungs, they will go to lymph nodes, to musculoskeletal tissues, to the abdomen, be it intestine, peritonitis, etc., to the genitourinary tract, and we have to remember that it can go also to the central nervous system. So let's look at that. Going to the lymph nodes here, lymph nodes at the neck, tuberculous lymphadenitis. We stop thinking about that. We think that it does not exist. And it will go to the eye. And there's the big issue of ocular tuberculosis causing iritis, iridocyclitis, vitritis, retinitis, choroiditis, vasculitis of the retina, optic neuritis, endophthalmitis, and panophthalmitis. So if we take tuberculosis uveitis, you have anterior uveitis, you have posterior uveitis, and you have the intermediate uveitis. So you are talking in posterior uveitis of choroiditis, chorotubercle, and choroid tuberculomas. Look at this paper, TB uveitis, and this paper was published some time ago. It's taking 10,000 patients with pulmonary TB, 15% developed ocular tuberculosis. Look at the numbers in underdeveloped or developing countries and in the developed countries. It's there, 16% in Kingdom of Saudi Arabia, in India 10%, in China 4%, in USA it's 1%, Italy 6%, Japan 7%. So it is not only the developing, underdeveloped countries, it's also in the developed world. So this is what you see, tuberculous choroiditis. And this is tuberculoma in the retina. And this paper from India, 2011, post-cataract endophthalmitis due to mycobacterial tuberculosis. So it can, some of the cases gets infected from other places in the body. Ocular tuberculosis with multiple cerebral abscesses. So combination of cerebral or brain being affected and the eyes being affected. Again, here it's choroidal tuberculoma. This is, of course, the optic disc. From USA, which is strange, again, but again, have to remember that this disease is resurging even in developed countries. 2010 from USA, intraocular tuberculosis. Again, from paper from India, 2013, ocular lesion in 1,000 consecutive HIV positive patients in India. So this combination of HIV and the immunocompromised patients, but remember it can affect the immunocompetent patients. A case of tuberculous endophthalmitis successfully treated with vitrectomy followed by anti-tuberculous agents, again in Japan. From Thailand, this paper about tuberculous panophthalmitis, again associated with lymphadenitis and CNS tuberculomas. You can see how the eye is affected. This can pass as bacterial conjunctivitis or something. People stop thinking about that. Stop thinking about TB. It's called forgotten disease. And my duty today is to tell you that this is not the case. Tuberculosis is still there and it is strongly there. It can go to the musculoskeletal system. So this is patients with tuberculosis of the knee. Can go to the testes, testicular tuberculosis. And coming now to the involvement of the central nervous system. As I said, there is not a single organ which is immune from tuberculosis, but the issue for today, the topic is the CNS. So let's speak about that. CNS tuberculosis. 10 to 15% of all tuberculous infections. It's a major thing. And everybody is feeling this complication of tuberculosis. And usually CNS is infected through hematogenesis spread, as we explained earlier. Now, to have CNS infected without evidence of pulmonary tuberculosis, this is very rare. And that's why I'm presenting at the end these two cases, one in the brain, one in the spine, without any pulmonary tuberculosis. You have to remember that. You don't need to see that the chest is affected to think of tuberculosis. You may have patients without any involvement of the lungs. So the CNS tuberculosis has two forms: either it is diffuse, like in the basal meningitis, or it is localized as a form of tuberculoma or cerebritis, like any other abscess, bacterial abscess or viral abscess or whatever, stage of early cerebritis, late cerebritis, and an abscess. So it can affect both the brain and the spine. So I'll take it first, the cranial tuberculosis. The way it affects the brain, either by forming TB meningitis, majority of the cases, this can progress to tubercular abscess. But we have to remember that also you may get 20 to 30 people with tuberculomas. Tuberculous meningitis, the commonest form of CNS or brain tuberculosis, basal meningitis. So like this. And when you do something like this, you will have the cranial nerves affected in the skull base. And people may die of tuberculous meningitis within weeks. Why? Because of the involvement of the basal meningitis, developing hydrocephalus. And remember that also tuberculosis can cause endarthritis of the trans, and then you'll get infarctions, ischemia, and so on. So tuberculosis can kill in 4 to 8 weeks because of the reasons I mentioned: endarthritis obliterans, hydrocephalus, and the drug-resistant cases. This paper from India, 2011, about the incidence of cranial nerve involvement in patients with tuberculous meningitis. Basal meningitis like this will surely affect third nerve, sixth nerve, and others. And this paper from South Africa about features of tuberculous meningitis in children. And this is very dangerous, tuberculous meningitis in children in Africa in particular. This paper from South Africa showing this. Again, if you pass the stage of meningitis, you may go into cerebritis, and this may progress into an abscess. So I've collected a few of these cases of tuberculous abscess of the brain coming in various forms and various locations. There is no place in the brain which is immune from tuberculosis. And I learned a long time ago from my bosses in England when I was training there that tuberculosis can mimic any disease, and it should go into the differential diagnosis of any cranial lesion. Various forms. Most of these cases are my cases, others are collected from literature. They could be single, they could be multiple. From India, this paper about acellular abscess and the pituitary. How often did you see that? But again, there is no organ which is immune from the tuberculosis. This paper from Brazil, again, showing these abscesses. Multi-resistant, drug multi-resistant tuberculous meningitis in patients with AIDS, which is understood from USA. Whether this patient is a native USA citizen or an immigrant, it doesn't make difference because we are having cases in the United States, in Italy, and in Japan, and Canada, and so on. From Mexico, 2010, again, tuberculous brain abscesses. Look at this. Abscess within the pons. It's very dangerous. It can be fatal. It was fatal actually in this case. Abscess could be extradural, or it could be subdural, and in children we call it subdural empyemas. Look at this here. It is interhemispheric. It can also eat the bone. This is from Turkey. And of course, it can affect the bone and causing bone osteomyelitis. And osteomyelitis can affect any bone in the body, including the orbit. Or if you don't get the meningitis or cerebritis or brain abscess, then you may get tuberculoma. And these tuberculomas could be small like this. And this is called miliary TB, miliary tuberculosis, or large tuberculomas. And there is something called target sign, like this with central necrosis. But this is not limited to the tuberculosis. Many other diseases can cause this target sign in tuberculosis. So tuberculomas could be small, they could be large. Actually, some of the cases like this, and I have seen cases, I have 2 cases referred to me as parasagittal meningioma, and they turned out to be tuberculosis. Again, various shapes of tuberculosis, various sizes. They could be small, they could be giant, they could be intraventricular, they could be anywhere in the brain. They could be supracellular mass, supracellular tuberculoma. And this you may miss as craniopharyngioma, as pituitary adenoma, and others. Tuberculoma here appearing in the cerebellum-pontine angle. Oh, is this vestibular schwannoma? Is this trigeminal schwannoma? Again, remember that tuberculosis can mimic any any pathology in the brain. This was also from USA. Other forms and funny shapes of tuberculosis. And I also was taught in my training in England, that was in the 80s, that whenever the lesion is weird, you have to think of syphilis and you have to think of tuberculosis. Maybe syphilis is finished, but tuberculosis is not. So the motto was, if it is weird, do Wizardman test. As I said, target sign is a feature of tuberculoma, but it could be any other lesion. So CT, intracranial tuberculosis, with a specific reference to the target sign as such. In South Africa, target sign is pathognomonic of intracranial tuberculosis. The reason being that South Africa is the highest recorded tuberculosis incidence in the world. So whenever they see target sign, they go, this is tuberculosis. But remember, target sign can be seen in addition to tuberculoma. I've seen it, and everybody has seen it in toxoplasmosis, in lymphomas, and in other diseases.
Yes, toxoplasmosis bothers.
You can see that it can also arise like in plaque. So again, this can easily be taken as meningioma or hemangiopericytoma and so on. And usually the features here may denote that this is a tumor, which is in many cases is. Some of these tuberculomas can be calcified. We know that some of the lesions can be calcified like this. And at the end of the day, tuberculosis can cause basal meningitis, and basal meningitis will cause hydrocephalus. It is communicating hydrocephalus in 41% of cases. And in those cases, you have to do either VP shunt or third ventriculostomy. And then there is the dilemma of, should we be putting a foreign body like a shunt in a patient with tuberculosis or not? A real dilemma. Again here, the tuberculosis can cause vasculitis, and vasculitis can cause infarction. So this is, I have to go back, this is the vasculitis here, and these are the infarctions caused by tuberculosis. Various types of infarctions caused by tuberculosis. And this paper from India about the patterns of the infarction in patients with tuberculous meningitis. So you can have bilateral basal infarctions or thalamic infarctions like this. This paper again from South Africa. Remember, this is the highest recorded place on earth with the tuberculosis. The distribution of brain infarction in children with tuberculous meningitis. Again, you can see here, frontal area, here in the basal ganglia. Tuberculosis can also cause sinus thrombosis with increased intracranial pressure. In this case, it has caused thrombosis of the transverse sinus. Let's go for spinal tuberculosis. What do we see? Spinal tuberculosis like this, you can see that we are dealing with discitis, spondylodiscitis. You can have a paravertebral mass, whether it is cervical, thoracic, or lumbar and pelvic. You can have collapse of the vertebra adjacent to the affected disease. And in this case, you may need to do surgery and do some fixation. Again, another dilemma, should we be putting fixation materials, metals, and etc. in a patients with tuberculosis? Extradural abscess, spinal abscess, extradural. Again, an extradural abscess in the cervical region, and here in the thoracolumbar region. Tuberculoma inside the spinal cord, intradural, be it intradural extramedullary or a pure intramedullary. In this case, it was pure intramedullary. In this case, it was intradural extramedullary. So tuberculoma can also present itself in the spine. Also, it can cause radiomyelitis, it can cause syringomyelia and others. And if you need to do surgery for these cases, it's very strict indications. Most of the time you need medical treatment, but sometimes you need to do surgical treatment, be it in the brain or in the spine. And the indications for the spine surgical interference is if you have cord abscess, if there is major progressing neurological deficits, and if the medical treatment fails. How do we diagnose tuberculosis? The famous name that we all know is Zeal-Nelson stain. Zeal-Nelson stain. It shows these rod-like, rod-shaped, small, acid-fast bacilli. Very diagnostic. But lots of us don't know that we are talking about two people, Zeal and Nelson. And this is a German bacteriologist, again, a German pathologist. So two people coining this name, Zeal-Nelson. Another way of diagnosing tuberculosis is using fluorescence microscopy, where these will be shown like this, shining in the back, the drop of a black, and the acid-fast bacilli are showing as bright yellow. The PS stain will show these lesions. And if you culture in Lowenstein-Johnson medium, it's a solid. You can also culture it in fluid medium, but a good culture is in Lowenstein-Johnson. And you need few weeks. You need 2 to 6 weeks to get this. You can go back to your patients and do tuberculin Manteau test, which is, as you see, it's here, or the IGRA test, the interferon gamma release assay. You can get CSF for analysis, and usually you'll get low glucose, high protein, and you'll get increase in the white PCs, mostly lymphocytes. So white PCs will increase from 10 to 1,000, lymphocyte predominance, low serum CSF in relation to the serum glucose, and you'll have high protein. So what about the treatment? Medical treatment is, in essence, in both cases of cranial and spine, and sometimes you need to go for surgery. Medical treatment, you start with 4 active drugs, which I will discuss in details for 2 months. This is the primary treatment, and then you continue the treatment with the 3 active drugs for at least 1 year. The first 2 months, the major 4 drugs, as I said, isoniazid, rifampicin, pyrazinamide, and others of the new drugs that has been introduced. For 1 year, the maintenance for 1 year is isoniazid, rifampicin, and vitamin B6. Second line of treatment that you may resort to in those resistant cases, streptomycin, which we all know that has its own complications on hearing and kidneys, amikacin, kanamycin, etc., etc. Those are second line. There is something called paradoxical worsening. You are giving the treatment, yet the patient getting worse, and there is increase in size during the treatment. So this is called paradoxical worsening, and then you have to resort to other lines of treatment in addition to the first line of treatment. What about steroids? Should we be using steroids? It's controversial. Some people say don't. Steroids will decrease the immunity of the patient and he is having tuberculosis. Others say you must. So it's controversial, but definitely both sides agree that if you have a case of tuberculous CNS involvement, and in case of meningitis, in case of acute encephalitis, or in case of the therapeutic paradox, as I just mentioned, or in cases of advancing hydrocephalus, and in case if you have tuberculoma with edema, usually tuberculomas are not associated with edema, but if you have, then you must use steroids. If you have tuberculoma, you have to continue the treatment for 18 months rather than 1 year. And as I said, in case of resistant cases, you have to add new other drugs and treat the case for a longer period of time, like 2 years. So I'll start with the case presentation. The two cases which I introduced first. Intracranial tuberculosis without evidence of pulmonary TB. This is very, very rare. Remember that without evidence of pulmonary tuberculosis, CNS tuberculosis is extremely rare. But here's one case. This is a 31-year-old male patient who came to us, to Jordan from Yemen, and Yemen is also endemic for tuberculosis. And he presented with posterior fossa manifestations, vertigo, unsteady gait, headaches, double vision, nausea. Examination showed that he has right sixth nerve palsy. He had cerebellar signs, tandem gait was impaired, and his gait was wide. Chest X-ray was normal, and his imaging showed this, which looks very much like a diffuse astrocytoma. Again here, misleading that the choline and Na, there are peaks, so you're speaking about a tumor. That's the danger that if you trust these fully, then you will fall in trouble. What about differential diagnosis of such pictures? Let's see how variations do exist here. Let's see differential diagnosis. I actually looked into the cases of mine and case in literature, which looks like the case which I just mentioned. This was cerebellar metastasis. This was metastasis from melanoma, hemangioblastoma, infiltrative medulloblastoma. What about that? The four types, the four histopathological types of medulloblastoma. Diffuse type is one of them. Ependymoma, hamartoma, ganglioma, ganglioneuroma, juvenile astrocytoma, teratoid, atypical teratoid tumor, ganglioglioma, astrocytoma, infarction, medulloblastoma, various other forms like other than the one we have shown, encephalomalacia, Lerner-Douglas disease, and others. So we opted to do the surgery, and I do my surgeries in the posterior fossa and the sitting position. We use the observation for cranial nerves monitoring, and of course, this is the operation theater. Sitting position is my favorite for these cases, and I will show you what did we find during surgery. So sitting position, this is the right side. I use the transverse incision because I want to avoid the fovea, going parallel with the fovea of the cerebellum. And look at this, it looks to me very much like an astrocytoma. So I was taking that tumor out and send it for histopathology, and my pathologist, Dr. Abu Farsakh, told that this looks like a granuloma. So we removed as much as we can from that without going into dangerous areas, without affecting the neurology of the patient, knowing where the dentate nucleus is. And again, the incision is parallel to the fovea and so on. So basically, this was not a tumor, this was granuloma secondary to tuberculosis. Okay. I don't know whether Dr. Hassan Farsakh is in the audience. Are you there, Hassan?
Yes, Dr. Rahim.
Right. Our pathologist, my friend, Dr. Hassan Fasha, we've been working together for some like 30 years. We know each other very well inside out. He's a fellow of American College of Pathologists here in Amman, Jordan, and he's a dear friend of mine. I will show the slides and you can comment on it, Hassan. This
Yes.
is the slide, the report. Many sections showing multiple non-caseating granulomas scattered in cerebral tissue. Rare granulomas show focal central necrosis. Many of the granulomas surround small capillaries. Cerebral tissue show active gliosis with the chronic inflammation. No parasites seen, no malignancy seen. So this is the first slide. Do you want to comment on that, Hassan?
Yes, you can see in this picture cerebellar tissue, and there are two granulomas like an owl eyes. These are granulomas. They have somehow predilection all capillaries. This is the low power view. Higher power, you can see again the two granulomas, and TB usually can be caseating and
Some interference with the...
and many times can be non-caseating. I want to diagnose TB only when you have the TB cases. Can you hear
No, there is lots of interference, Hassan, with the voice.
me well?
There is lots of interference.
So this is non-case to another.
Yes, the voice now is better.
Is this better now?
Yeah, much better. Yeah, go on.
Somehow. Okay, it's better here. So you learn that
No, we've lost the voice.
TB is commonly present with non-caseating granulomas. TB can, hello?
Hello. The voice is,
Hello.
you know, sometimes it's clear, sometimes it's not. So maybe if you change your position, maybe that would work.
Yeah. One.
You know, Hassam, if you take off your picture, that will save bandwidth and we'll be able to get your voice. So turn off your camera. And we still can't hear you. Just turn off your camera. That will give us enough
Hello,
band-
can you hear me?
Yes, very clear.
Yes, yes.
Yeah, you see, TB most commonly when present with granuloma, TB almost always have granulomas, but most of the granulomas in TB are non-caseating. So if you want to diagnose TB with caseating granuloma, you will wait really for a long time to have this diagnosis. So when there is a non-caseating granuloma, always suspect TB, because TB can cause non-caseating and caseating granulomas. And actually, most of the time, as a pathologist, we see them as non-caseating granuloma. I want to emphasize this point because many clinicians, and even sometimes I see that the people that treat TB in Jordan or in other countries, when the pathologists mention these granulomas are non-caseating, they rule out TB. No, this is wrong to rule out TB because they are non-caseating. This point, I want to mention the other point. TB actually has more than TB is only one strain of mycobacteria. So this is another granuloma around capillaries. TB is we cannot differentiate between the other different types of mycobacteria, and sometimes the treatment has some implication to different strains. For example, in our lab, we do PCR for about 10 different strains of mycobacteria. Mycobacterium cancer, Mycobacterium avium, intercellulari, and there are about 10 other common mycobacteria. And they all, sometimes, or most of the time, they present histologically the same. So you have always to ask if you can submit fresh specimen for PCR to give you the exact type, whether it is TB or other strains of mycobacteria, because sometimes the treatment is difficult in these atypical mycobacteria. So you have to treat the patient probably for longer time. In this picture, we can see this is higher power picture. Typically, TB present with Langerhans giant cells. You can see the next picture. Langerhans giant cells. You can see these giant cells usually contains about 20 or more nuclei in the periphery of the picture. And typically, the Langerhans giant cells in TB is different from foreign body giant cells. The Langerhans, usually the nuclei are in the periphery of the cytoplasm, where the foreign body giant cell nuclei usually are scattered inside the cytoplasm. And very important for pathologists to mention whether this type of giant cell is Langerhans type or it is a foreign body giant cell type, because the clinician and the treating clinician, his way of treatment will differ which way of giant cells are there. So Langerhans usually are present when there is TB. And you can see usually with TB, we see sometimes neutrophil and actually many times neutrophil and necrosis. And this is a case where also this slide shows the necrosis and neutrophils in this area. So it may make mus or a bacterial infection. If you have to search sometimes for granulomas to call it granulomatous meningitis or encephalitis. Next slide. This is another area where you can see inflammation and necrosis in this area, although this is not typical of caseating necrosis. Next slide. So we did acid bacilli and it's negative. So when you have, this is important, in our practice, acid bacilli actually has very low sensitivity. It's really specific for mycobacteria. It's not specific for TB. But when it is negative, that does not rule out TB, because it's only positive in about 20% of the cases. The other 80%, really you have to do other tests. And I usually encourage the clinician to submit tissue for BCR. And in this case, we did not do BCR. We have to search when there is granuloma. We always have to search for fungi, parasites. So we do all the special tests like PS and GM-10. This is to rule out other fungi or parasites. And we also do stains for spirochetes. I also want to mention one important thing Dr. Ibrahim mentioned about AGRA test or interferon test. Now we have two important blood tests for mycobacterium. One of them is interferon or golden interferon test, and this measures the serum gamma interferon in the serum. And the other test called T-spot test or Heliospot test, and this is actually more common now in England. It measures the number of activated T cells that express interferon. And we have this test actually in our lab. And almost always, when we see this test is positive, this indicates that this patient probably has a TB in many cases. So it's very important for the clinician to know what test the pathologist can afford to help him diagnosing TB, because diagnosing TB is not easy. Many times it's really difficult, and many times can be in other differential diagnosis of other bacterial infection or other fungi. So ask your pathologist or lab to all the possibilities, how to be sure about which type of mycobacteria or strains that's affecting this patient.
Thank you, Hussam. Thank you very much indeed. So the final diagnosis that this was a granuloma from tuberculosis. And at this juncture, we consulted with my friend, Dr. Muntasir Balbisi, the infectious disease consultant here in Amman, Jordan. And are you around, Dr. Balbisi? No, he's not. So he advised to give us the 4 agents, isoniazid, rifampicin, pyrazinamide, and rifloxacin for 2 months, to be followed for 1 year by isoniazid, rifampicin, and vitamin B6. As in the book, we followed that case MRI for many years, and I'm just showing you the last MRI 5 years later, absolute cure of the disease. It was not a tumor, it was tuberculoma, and it was diagnosed well and treated well. So no evidence of the disease whatsoever after 5 years. The other case is the spinal tuberculoma. This is a very short case because we discussed everything about it. Again, here the unique thing about this case that this is spinal tuberculoma without evidence of pulmonary tuberculosis. Again, without evidence of pulmonary tuberculosis, CNS tuberculosis is extremely rare. That's why I choose these two cases for presentation. This was actually a doctor, a general practitioner here in Amman, 42-year-old male patient with a few months history of fever, night sweats, and malaise. He was diagnosed as tuberculous meningitis, and his CSF showed white PCs with lymphocytosis, increased protein, and decreased sugar, like any case of meningitis. Again, stress the point that he had no primary tuberculosis. He developed left lower limb weakness, and he showed sensory level at D9, thoracic 9. And these are his preoperative pictures, again showing this intradural mass, which looks like granuloma or something, or a tumor, but it was pressing the cords in a big way. So you can see it in the AP view. You can see before contrast and after contrast. So we did not know whether we are dealing with a tumor or with whatever. So we opted to go for surgery. And I'm showing you this surgery now. I played with the colors so that you can see the difference, because this is an old film. This is back in '97. So I changed the pictures that or the colors so that you can see. We are opening the dura now. This is a very thick dura, and inside the dura we could see a mass which was intradural extramedullary. So trying to separate it from the dura first, and then separate it from the cord. Remember, this is at thoracic, mid-thoracic area, D7. Opening a very thick dura here. Using the ultrasonic aspirator to remove this mass, which was a real mass, rounded, thick mass. Here, trying to separate it from the roots and from the spinal cord. So again, basically, this is it, some calcification. And we'll stop here. Again, the report was sent to Dr. Farsakh. We just mentioned that, so we're not going into details about it, but it was the same thing, that this is a granuloma. And this is one of the slides of the histopathology. And this is his post-operative pictures, and of course with medical treatment, the same lines of treatment that we treated the first cerebellar case in the brain, we treated it in here in the spinal case. And this is the follow-up of the patient's disappearance of the mass, and the patient went back to his practice as a general practitioner. So with this, I finish, and I'm ready to have your questions, if any.
Okay. Eleanor's going to try to moderate. Are you there, Eleanor? Okay, I have a few questions, Dr. Sabeh. Let me just go ahead.
Sure.
Avaz Ismailov is asking, how can we differentiate vertebra in tuberculous to metastasis before biopsy?
Is that in the spine, he means?
Yes.
Obviously in the spine.
Yes.
You can, because the metastasis will not affect the disc. The disc is avascular. So discitis means that you have a bacterial infection, tuberculosis, etc., while metastasis will come to the adjacent sides of the disc. So one can differentiate radiologically metastasis from tuberculosis.
We are graced with the presence of one of the most famous neuroanatomists in the world, Victor Perez.
Hello, Victor.
I'm sure he has some comments on spinal tuberculosis. Hello, Victor.
Hello, Victor.
Hello, John Bennett. I'm just aficionated to neuroanatomy, not great anatomist, just anatomist.
Oh, okay.
Lecture, Dr. Ibrahim. Very nice lecture. The cases that you show us about cerebellar disease and also spine are really, really demonstrative of this particular disease. So we in Mexico have not many cases, but we have little experience about this disease. I think probably you have more than us, probably, I don't know. How many cases
How many cases I have? Lots of cases. I was just talking to John before we started the transmission that Jordan is a medical hub in the Middle East, and we get lots of patients coming from the Arab world around us. I was just telling John that the income from the medical tourism in Jordan is something in the range of $1.5 billion a year. So lots of patients come to Jordan. Jordan is only 10 million population, but lots of patients come from the surrounding Arab countries, and we have lots of cases coming to Jordan with tuberculosis from Yemen, from Saudi Arabia, and so on and so forth. So we have lots of cases, and we are experienced in dealing with this kind of pathology.
Thank you. Thank you, Ibrahim.
Okay, we have a question, Dr. Sabea. How likely is the probability of CNS infection of tuberculosis, and is surgery usually required?
If one diagnoses the case that it's just tuberculosis, usually you start with medical treatment. Unless the patient is going off with major weakness or major neurological deficits, then you have to go for excision or biopsy to make the diagnosis. It is 10 to 15% of CNS infection in tuberculosis in general. So it is frequent.
Okay, we have Uday Gupta from India. He spent a lot of time with tuberculosis. Hello,
Sure.
Uday. Do you have some comments you want to say to Dr. Sabea?
Hi. Good evening, Dr. Ibrahim.
Hello.
I want to put here. Sir, we dealt with the case of a cranial tubercular patient. I mean, the management of tuberculosis in cranium depends on the stages of the tuberculosis, like stage 1, whether it's a late presentation.
Sure.
So we decided to go for a shunt. What is your, similarly, it was the option whether to do a shunt or whether to do a ETV in hydrocephalus. What would you suggest? We shunted that patient.
Yeah, it is a dilemma. Putting a foreign body in a patient with tuberculosis is always a dilemma, be it in the cerebral, putting a shunt, or in the spine, putting fixation material or whatever. But if you have to do it, you have to do it. Lots of people do it. But I would prefer to go for third ventriculostomy rather than putting a shunt. Again, people may say this may spread the disease. I would say no. Third ventriculostomy is much, much preferred for a shunt.
Yeah.
And in general, sorry, go ahead.
Yeah, present day is better to do an ETV like this.
Yes,
absolutely. But in a morbid patient in the poor GCS, what would you suggest?
Well, you have to go for a shunting procedure in that case because you are forced to do it. So, but lots of people have put a shunt in and they just continued with the antibiotics and they just did it.
Another case we had of a spinal TB. So the patient was developing a kyphotic deformity. And would you suggest the minimal invasive better option than an open procedure, open fixation?
Again, minor procedure or major procedure, I'm not.
I mean, minimal invasive versus an open fixation.
Sure. Usually, you want to go for the minimum as possible to treat your patients. But generally, if you need to do fixation, you do it with minimally invasive or major invasive. I'm against this terminology, the major invasive and minor invasive, because you need to do whatever is needed for your patient. So yes, you can go ahead and do the fixation if needed.
Thank you. Thank you.
Thank you.
Okay, we have another question. Which location within the brain is the most common for tuberculosis and why?
Simply, this is hematogenous spread. And with hematogenous spread in general, when you come to the carotid artery, then you would go and choose to go through the middle cerebral artery because it is a continuation of the middle cerebral. So usually you will find tuberculosis in the territory distribution of the middle cerebral. But again, having said that, we have seen lots of pictures during this presentation. It can affect the frontal lobe, the posterior fossa, the posterior circulation. There's not a place in the brain, there's not a place in our body which is immune from tuberculosis.
Okay, Pragnesh Bhatt, do you have a question you want to ask directly? Pragnesh?
Thank you very much for giving me the opportunity. In fact, I just wanted to respond to the question about the diagnosis of tuberculosis versus metastasis. I have already written the dictum on the chat box, but due to the hematogenous spread and due to the embryological development of a somite, which includes the lower half of the upper vertebra and upper half of the lower vertebra, usually in discovertebral osteomyelitis, which is either tubercular or non-tubercular, the disc gets involved, and therefore our standard teaching to the medical students is when the disc is bad, the news is good because it is usually infective and can be treated successfully with anti-tubercular or antibiotic treatment, as against the metastasis where bone is involved and the disc is spared. So therefore we say that the disc is good, the news is bad. Thank you very much for giving opportunity.
Thank you. That's very, very much correct. Thank you.
Okay, we have a question. Are tuberculosis abscesses in AIDS more common?
Is tuberculosis common in?
More common in AIDS patients.
Yes, it is, definitely. As I said, the resurgence of tuberculosis occurred in the 80s and in the 90s with the increase in number of AIDS patients. So definitely they are related. Your immunity compromised, you are affected with tuberculosis.
Okay, what are the common tumors other clinicians mistake for tuberculosis?
It can mimic any pathology. To me, it can mimic any pathology. It can mimic meningioma, hemangiopericytoma, astrocytoma. It can mimic anything. And even if you have subdural collection, tuberculosis could be the cause. So tuberculosis should be in the differential diagnosis of any cranial and spinal pathology.
Yeah, that was a good question. What vertebra, if any, are the most commonly affected and why?
Thoracic, because of the drainage system there. Thoracic are the commonest in the spinal column for affection by tuberculosis. I see Benedicto Colli there. Are you there, Benedicto? Hello?
Unmute yourself there, Benedicto.
Hello, I am here. Brian, I have
nice to see you.
Nice to see you. I have a question for you. How you diagnose of tuberculosis? Because the pathologist said you that is a granuloma. How do you know that is tuberculosis? Because in our experience, it is very difficult to find the Mycobacterium in tuberculomas.
Yeah.
We only find in abscess.
True. I agree with you, Benedicto. It's very difficult sometimes to diagnose. Doing the test and the images and the histopathology, sometimes you have difficulty diagnosing tuberculosis. And you alluded to a very important point. If you take a culture, you will find other infections super added to the tuberculosis infection. So sometimes you don't find the rods typical of tuberculosis. So taking a biopsy, you have to be doubtful and be sure that this is not a secondary infected case and so on. Sometimes it is really difficult. Even the pathologist might find difficulty doing this. Culture will take a few weeks. The serology test can be negative, false positive and false negative. So some of these cases can be really difficult. In addition, that some of these cases are resistant to the treatment. Tuberculosis can be a killer. And that's my message. And that's my take-home message is that there are lots of cases of tuberculosis in the world. We have to diagnose them well, treat them well to save lots of life.
Okay, Avaz, go ahead. You have something to say? Go ahead, Benedicto.
No, thank you very much. We have some cases of tuberculosis and other parasitosis. Sometimes it's very difficult to differentiate. From tumors, it's not too easy, too difficult, but from another kind of parasitosis as mycosis is very difficult to differentiate.
True, absolutely.
Okay, let's see, do you see any more questions, Dr. Sabea? I think we have a couple more.
So we had
Go ahead.
So we had a patient of psoas abscess, which was just averting the spinal canal, but she had a good neurological. There was no neurological deficit, so we kept under observation. Planned to decompress and drain it. What would you keep it conservative or again surgical? We had the option to debride it and drain it.
So long you are treating her medically and she is not getting worse, then you can continue the medical treatment, of course. There's a question about do you have an experience of brainstem tuberculosis? In my practice, no, but in the literature, yes, there are lots of brainstem tuberculosis, and I showed a few of these cases.
Sammy Khatib asks, does the treatment of CNS TB medically, is it as effective in other parts as in other parts of the body?
No, just the same, but CNS has its peculiarity, it has its importance. So you have this urgency in treating these cases, and you don't have the leisure of waiting for results. Sometimes you have to make decisions and make decisions early and quickly because you are dealing with the brain, not with, say, the lungs or the musculoskeletal system. Mm-hmm. That's the peculiarity of the CNS infection. That's the uniqueness of tuberculosis in CNS.
Okay, and excuse me. Nativa asks, she's from Uganda. Let me get her question here. Let me see here. I lost it. How do you distinguish a tubercular abscess from another abscess on a CT scan? Is it possible?
No, you're just dealing with an abscess. So you have to take everything in consideration, the history, the physical examination, the blood test, everything there to reach the diagnosis. Sometimes you can't. And then you have to go for a drainage of this abscess, either by tabbing it to get some specimen or by just taking it out.
Very good. Natambi is a medical student from Uganda, 5th year. Okay, we have a question from AJ Singh. What is the most common part of the vertebra that is involved with tuberculosis?
Thoracic vertebrae are the commonest.
Okay. Let's see, does anybody see any questions that I missed? Dr. Sabea, you answered a lot of questions.
Hey, sorry, can you hear me? Okay.
Yeah, yes, go ahead, Ella. Go ahead.
Incredible. Amazing. Apologies again for the bad connection. But from questions from earlier on, you mentioned cerebral tuberculosis. Would be spinal or cerebral more common?
You are asking about which is common, the brain or the spine?
Yeah, so spinal or cerebral tuberculosis.
Yeah, spinal is commoner than the brain.
Incredible. I think that's all the questions we have at the moment.
Okay, very good.
Unless anyone else has.
Yeah, anybody else in the panel have a question of Dr. Sabea or comment? If not, Dr. Sabea, that was a very great session, very interactive. You answered a lot of questions.
Thank you, John.
So I'd like to thank you very much. Now, do you have any topic for next week yet?
Yeah, in 2 weeks' time.
2 weeks, okay.
Next week I have a session with Kike Terrell about complications in neurosurgery. So our next session will be in 2 weeks' time, and I'll speak about the spinal, basically cervical dumbbell-shaped schwannomas in the cervical or the spinal regions. A very tough topic to discuss.
Okay, we'll be advertising that, and thank you all the panelists for coming. Elena, we tried. Technology wasn't agreeing with us today, but we'll be back in a couple of weeks. And I'd like to thank
very
everyone.
Sorry. I hope the questions were still helpful.
No, you gave me some good questions.
The questions are still okay.
Okay, you came through. So thanks everybody for coming.
Thank you. Bye-bye.
Bye-bye.
Thanks.
Thank you.
Bye-bye.
Thank you so much.